Hello, everyone. My name's Justin Dourado. Like she said, I'm from FAU in Florida. Thank you all very much for having me. I'll be talking about ureteral stenting and elective colorectal surgery. We have no relevant disclosures for this talk. Background, ureteral injury is a rare but dreaded complication of colorectal surgery. Depending on the source, the rates are anywhere from 0.2 to 7.5%. This risk is increased with more intra-abdominal adhesions, so reoperative surgery, metastatic cancer, and significant preoperative weight loss. Ureteral stenting has been suggested as a method to avoid injuring the ureters during surgery, but data on the actual benefit of this intervention is incredibly mixed. Some studies show increased complications with no benefit of injury. Some studies from the NSQIP database do show lower injuries. It's incredibly variable and there's no good consensus. But pardon me, one of the main things that is noted is they do, in most studies, increase complications for patients. The addition of indocyanine green to these stents has been advocated to improve their visualization. This can be utilized both in a laparoscopic and robotic platform with some slightly more cumbersome but still available ways to utilize it in an open setting. And many centers advocate for doing this in reoperative cases or cases with bulky oncologic disease to visualize when you have a difficult pelvic sidewall dissection. But still, there's been no proven benefit to reduce injury. So we conducted a retrospective cohort study at a single community center in Florida with multiple surgeons, both colorectal and general surgery, trained over a 2-year period. Our cases were patients that underwent ureteral stenting and the controls had no stents. All patients underwent an institutional ERAS protocol, and all patients who had stents had indocyanine green injection, and all of our minimally invasive colectomies at our institution were performed robotically. There were no laparoscopic cases in this series. The ICG injection was done in a specific way. A 4 French open-ended ureteral stent was partially placed into each ureteral orifice by urology. 5 cc's of ICG was injected into each stent, which allows for binding to the ureteral endothelium. This is an off-label use of ICG. And then the completion of the stent insertion was done. All adult patients undergoing a colectomy with open and robotic surgery were included. Emergency surgery, patients less than 18, and inadequate data on the stents used or use of ICG were excluded. Primary outcome was the rate of operative complications, including ureteral injury. Secondary outcomes were overall complications, length of stay, readmission rate, and pain control. Statistical analysis was done in a fairly standard fashion with EZR and R, chi-squared and Fisher's exact test for categorical, students T and Mann-Whitney U, pending normality of distribution, and ANOVA if there were more than 2 groups, and we used P less than 0.05 for significance. 251 patients met inclusion criteria during our study. The average age was 69 with an average BMI of 26. There were little less than half males. We had no ureteral injuries in our cohort. And 100 patients had no stents and 151 had ureteral stenting with ICG. In terms of demographic factors, the only thing that differed between the 2 groups was that the patients without ureteral stents were slightly sicker, had a higher ASA status. Operative details, we were more likely to utilize ureteric stents when we were using a robotic platform rather than open surgery. We had a lower rate of conversion to open surgery when ureteral stents were used during robotic colectomy. It did increase the operative time, and likely unrelated but still significant is when we used stents, we were also more likely to use a rectal tube and a Foley. In terms of complications, there were no differences in infectious, retentive, hematuria, any complications postoperatively between the stenting group and the non-stenting group. The length of stay was a day shorter, but it didn't reach significance. No change in discharge disposition, but we did have about a 20% lower readmission rate in our patients that underwent ureteral stenting. In conclusion, we had no increased complications, length of stay or infection, or urinary retention with the open-ended ureteral stents placed in the way that I mentioned. This is possibly because of a change from larger lighted stents, more routine use by our urology colleagues, which could cause less ureteral trauma, and the use of ICG combined with the robotic platform. We showed a lower conversion and a lower 3-day readmission. So at our institution, at least, we feel that the routine use of ureteric stents in this way offsets the increased cost by saving on conversion and readmission on these patients. Thank you very much. I'll take any questions.